Welcome everyone, thanks for coming. Thanks, welcome to Women's College Hospital and the site of TAPME. And so I'm going to introduce our guest speaker today. A lot of people know who he is already. So I'll give you a little bit of history of how he got here. The Royal College of Physicians and Surgeons of Canada has established the McLaughlin-Gallie Visiting Professorship in 1960. And that professorship commemorates outstanding contributions to the surgical science of William Edward Gallie of Toronto. And Dr. Gallie is a former professor of surgery and the Dean of the Faculty of Medicine at the University of Toronto. And he, this year's theme was opioid safety. And Dr. Peter MacDougall is the invited speaker that won that award, and he's a professor at the Department of Anesthesiology, Pain Medicine, and Perioperative Medicine at Dalhousie. He practiced family medicine and anesthesia in rural Ontario and Nova Scotia before moving to Halifax. He's the founder and director of the Atlantic Mentorship Network, Pain and Addiction, and a co-developer of the prescribing course, Safe Opioid Prescribing. So we're going to have a very interesting talk today about the prescribing crisis. And here's Dr. MacDougall.
Thanks very much. So I want to say thank you to a number of people. Before I start, this is a huge honor to be here to do this talk and to visit what is an amazing pain center. And Tanya and all of her colleagues have done such a great job. There's a lot of people I need to thank for this. I'll start with my family, who without family you don't do anything. But even here today I see a number of people who were instrumental in getting me to where I am today. I see David McKnight and Peter Slinger and out there, Philip Payne, Norm Buckley, and another guy sitting over there, Michael Cord, who's been a huge mentor over the years. And I just want to say that this is the work of many people. And it's the result of a lot of years of their influence. So, again, thank you to everyone. By way of disclosure, I work for the Nova Scotia Prescription Monitoring Program as a consultant, and I provide expert content review for various prescribing courses and whatnot, both for colleges of physicians and surgeons, and also most recently just for the Calgary program. I'm co-author and co-director of the prescribing course. My colleague, Dr. John Fraser, who's a good friend and also a huge mentor, worked with me on this. And the Atlantic Mentorship Network is a network of physicians and interprofessional group across Atlantic Canada, and was tightly linked to the Medical Mentoring for Addiction and Pain Network here in Ontario, which was headed by Dr. Cord there. I want to sort of talk today about what I think of as a perfect storm. A storm that started some years ago and really had three phases. And we got here to where we are not by one simple thing, but by a number of things. And that's the storm that I talk about. Really, the three phases are the first part where we recognized that there was a problem coming and started looking for ways to manage it. And then there was sort of this interim phase in the early part of the 2000s and up to about 2010, where we thought we had a great answer in opioids, and we prescribed them in large numbers for many reasons, and realized that we had a bigger problem on our hands than we started out with. And now there's this third phase that I think of where we are now, where we've really got ourselves in a pickle and we have to try and get our way out. And in fact, there's a huge shift, and I think a number of really important initiatives that are helping us to make our way out of this problem. Prescribing crisis is really two parts. I was just going to talk about prescribing initially, but then I thought, well, because there's this whole fentanyl issue out there, and I thought, well, they're quite separate and I don't want to mix them up. But really, I don't think that they are separate. And what I'll talk a little bit about is how what started out as a simple problem really created a second problem, as a sort of squeeze the balloon, as it were. And the whole thing, I think, had its genesis about 75 years ago, at the end of World War II, when tens of thousands of military personnel returned from the Second World War. Those people then produced children, about 4.5 per household, and those children created what was known as the baby boom. And those children were part of a very unique generation in history. They are the best educated, most affluent, most prosperous generation in history. They bought houses, they created an economy, they did all those things, and mostly what they did is they grew older. And like most of them, myself and some of my colleagues, we've grown older, and we've created this bulge in our population here, from 75 down to about the age of 55. It was a much more dramatic bulge about 20 years ago when it was the big thing coming, but now we see that the echo generation's following. But we recognize that this bulge was coming because if you look at the generations before, they were much smaller. Because this generation has lived longer than any before it. And that generation, as they age, started to recognize that they were enjoying the fruits of longevity, chronic illness, diabetes, heart disease, arthritis, so many others, including chronic pain and substance use, addictions. And policymakers and governments in the 1980s and 1990s recognized that there was this huge wave coming and that chronic illness was going to be a problem and that we were woefully prepared to manage it. So they responded by creating more physicians and more healthcare providers. More of the same. So the education systems didn't really change at the time, but we had more spots to educate more people in the same manner. In the same manner being the manner that we treated acute illness. So we talked about treating acute illness, but then we're trying to treat chronic illnesses as acute illnesses. Our pharmaceutical colleagues also saw the problem coming and saw the opportunity. And at that time, they recognized that the opportunity was to create more product. So they created new products, new antidepressants, new pain medications, and they reformulated old pain medications into longer-acting formulations. And they also recognized where the rest of us had left a vacuum. In the early days, there was a search for new treatments for chronic pain and trying to figure out how can we manage this, what we see as a huge illness coming down the pipe. So there was a move to look at an old group of medications, the opioids. This is some work from Dwight Moulin's group. It was published in The Lancet and has been widely quoted. It's one of the first trials of opioids for chronic non-cancer pain. It was 6 weeks long. Most of the studies are 4 to 6 weeks in length, the longest being 13 weeks. But this is widely quoted as evidence for the use of opioids for chronic non-cancer pain. In 2002, this study was published, and this, again, a Canadian study, and I've left the names in because, well, it's published, but also I don't want to leave the impression that I think in any way that anyone was doing anything untoward. I think the people doing this work definitely were trying to find the best way to treat their patients, and they had the best interests of their patients and the public in mind. But I've put in I copied the interpretation of it, and what was interesting to me when you read this study, because this is an important study, it was one of the first in Canada to lay out the prevalence of chronic non-cancer pain and pegged it at about 20%. But it also looked at the role of opioid analgesia, and particularly strong opioids. And what they said was, despite growing evidence supporting the efficacy and safety of major opioid analgesics for chronic non-cancer pain, less than 10% of patients were taking prescription medication were treated with strong opioids. This is in 2002, and the data would have been a little earlier than that. So, and I also put the acknowledgements for the funders. So Janssen Ortho funded this. Janssen Ortho makes fentanyl, strong opioid. They also make tapentadol, but tapentadol wasn't available then. The next year, they published this study, another survey, Attitudes Toward Opioid Use for Chronic Pain. So this was targeting palliative care physicians and chronic pain physicians and their attitudes toward using opioids, or strong opioids, particularly for the treatment of chronic pain. And what I find particularly interesting is the wording of the conclusions. The conclusions state that there is a reluctance to use opioids for severe non-malignant pain, and there's a need for improved physician education. And the implication there is that we were not doing all that we could, and we could do better if we just weren't so reluctant. But there was very little evidence to back up the use of opioids at that time, and even to now. Again, acknowledgements to Janssen Ortho. And at the time, and as I'll show in a moment, there is a reason that pharmaceutically funded studies were so prominent. And it's because there wasn't any other money. We saw early on, in the late 1990s and early 2000s, a shift in what was going on in terms of morbidity and mortality. The data was there early on that there was a problem. We look here, you can see that this is US data, but Canadian data is very similar. We can see that opioids, that's the graph up here, opioids, methadone, and synthetic opioids, so oxycodone and fentanyl, deaths from those drugs were on a dramatic rise. But what wasn't rising was deaths from heroin. Deaths from heroin were actually slightly declining. So prescribed opioid deaths were vastly outstripping opioid overdoses from heroin. And this was up until from 1999 to 2006. The Canadian Drug Use Monitoring Survey from 2009 showed similar data. So what they did is they surveyed 13,000. There was 13,000 people responded, and 2,700 pharmacies responded. And Benedict Fisher pulled this data out of the survey. What they showed is that 20% of Canadians, which equated to 6.7 million people at that time, had received an opioid prescription in the previous year. 5% had used it inappropriately. They used this long non-medicinal prescription opioid analgesic use term, but really what they meant is aberrant opiate behaviors. So borrowed some, stole some, used more than prescribed or higher doses or something. That's 1.7 million Canadians were using opioids inappropriately. 0.4%, or about 140,000 Canadians, admitted in the survey that they were using them to get high. And to put that in some perspective, if you think about the Air Canada Centre, the amount of people that would be there for a hockey game, there would be 80 to 90 people in a crowd that size who would be using opioids to get high. That's despite the fact that they're Leafs fans. We saw, and Benedict Fisher, this is more of data from Benedict Fisher's group in BC, that as the doses of prescribed opioids went up, so the defined daily doses as they went up, so did the mortality rate. So there was evidence early on, and very clear evidence, that increased prescribing of opioids created increased mortality. We also saw, and this is at the height of the prescribing in 2007 through about 2010, we started to see other problems emerging. The makers of OxyContin pled guilty to essentially false advertising, telling us that OxyContin was less addictive than any other opioid. They made a very small settlement in Canada, but that took 10 more years to come. And in fact, those legal issues go on to this day. So there is still court cases and whatnot going on here in Canada around this issue. What seemed to have shifted things, and I think one of the most important things that happened was in 2010 in Canada, the first set of Canadian guidelines was published. This is an important document, and I think it's still one of the best set of guidelines out there. And I think it was important because it was based on all the available evidence. It was created by a group that were quite widely representative of Canadian pain and opioid physicians across the country. And mostly it outlined what in fact is a process for safe prescribing. That's embedded in those guidelines. And it started a shift in the conversation of how we deal with the prescribing of opioids. That was followed in 2016 by the American guidelines, which were similarly based on evidence, but were somewhat more prescriptive. This is where we first saw upper doses of 50 to 90 oral morphine equivalents for prescribing. Those guidelines had a profound impact here in Canada because at that time, a number of colleges started to look at it, particularly BC and Nova Scotia. BC adopted these guidelines as a standard, and a standard means thou must. So what happened almost immediately after was that physicians either abandoned prescribing opioids altogether, or they started rapidly tapering people's opioids, or simply just pulling people off opioids, and there was a huge pushback against the guidelines, particularly out west. On the other coast, in Nova Scotia, the college said, well, we're going to adopt them as a guideline, or thou should, rather than thou must. And there was similar pushback, but not quite as strong, because to some degree the college did some education in the community and risk management. But still, there was a fair bit of pushback. And I got countless phone calls from terrified physicians worried that they were going to have their license pulled because they had patients on doses over 90 oral morphine equivalents. The following year, the second set of guidelines was published here in Canada. Now, the first set of guidelines in 2010, one of the biggest criticisms was that a number of the guideline committee members were heavily influenced by pharma. This set of guidelines came out, and despite efforts to prevent it, there was still pharma involvement in the guidelines, but only one person. And however, there was still some pharma involvement in the rollout of the guidelines and the development of education programs. Again, based on evidence, very, very similar to the American guidelines. And they really laid out a set of guidelines that suggested for new starts, you shouldn't go above 50 oral morphine equivalents without any evidence of improvement, and you shouldn't go above 90 without at least checking with someone else. And if you have people on higher doses, you should attempt to taper at least. That's sort of the way they read. There's much more to it, but the guidelines are based heavily on evidence, and there was a fairly good representative panel, although mostly from central Canada. So where are we right now in terms of prescribing and the opioid crisis as a whole? Well, in Canada, this is data from this year. It goes up to the third quarter of last year. By the end of August of last year, almost 3,300 people had died of opioid overdose in Canada. By the end of the year, it was about 4,200 people had died. And this is from opioid overdoses, and heavily weighted, of course, to BC, because that's the port of entry for fentanyl, and also in Ontario in many ways simply because of the size of the population. The deaths from opioid-related causes are concentrated primarily between the ages of 20 and 60, which, if we think about it, is the ages when people are most productive. That's when people should be raising families, working, contributing to the economy, paying taxes, staying out of hospitals. But in fact, they're dying in disproportionate numbers from opioid overdose. Over 10,000 people have died in that 3-year period. If any other disease had killed 10,000 people in a 3-year period, we would have been much more concerned. It also costs us a lot of money. Opioid-related hospitalizations have been on the increase dramatically over the past few years. And this data is just presentations to hospitals with opioid overdoses. It doesn't capture the morbidity associated with the infectious diseases that go with opioid use. So things like hepatitis, HIV, abscesses in places that I never knew you could have abscesses, epidural abscesses, psoas abscesses, intramuscular abscesses, cellulitis, endocarditis. All of these things land people in hospital for extended periods of time on expensive antibiotics for weeks and weeks on end sometimes. And then they get released from hospital only to return a short time later. So enormous amounts of money being spent on this. This affects small and medium-sized communities disproportionately. And if we think about where the communities that are most affected by economic downturn. So at the height of the opioid prescribing was right through the period of time when the economy collapsed in 2008 and 2009. Many of those small, medium-sized communities that were dependent on one or maybe two industries were hardest hit. So then you add into all the other determinants of health. You add job loss, loss of hope, poverty, etc. And these communities are even harder hit. This bit of data is, I think, some of the most important that I've seen. It comes from the Public Health Agency of Canada. And if you look at the gray bars, this is from 2016 to 2018. In 2016, opioid deaths from fentanyl and prescribed opioids were about equal, slightly more in the prescribed opioid department. Over the next 2 years, you can see that the deaths related to prescribed opioids drop off. So, and they drop off in 2016, around the time that the American guidelines landed and the Canadian guidelines were coming on. And fentanyl deaths started to rise. So by the third quarter of 2018, depending on how you look at it, deaths related to opioid prescribing are only implicated in 25% of opioid-related deaths. Or you can say it another way and say, prescribing of opioids is responsible for 25% of opioid deaths in this country. It's hard not to draw the conclusion that the fentanyl deaths and opioid prescribed deaths related to prescribed opioids are not related. As you can see, it's not causation. You can't prove that with this data. But certainly the implication is there. And it tells us that we as prescribers, as physicians, probably have some responsibility for both problems. Certainly for prescribing, and maybe for squeezing the balloon in how we deprescribe and leading to other problems. So opioid prescribing has certainly come down in Canada. This is national data on the defined daily doses. Up until 2016, we see a gradual decline. I used Nova Scotia data, but for the next few slides, because because I had it and it was clean. But we saw starting in 2012, actually when I took this data back to 2008, we could already start to see some changes occurring. But there's a decline in the amount of opioids being dispensed from pharmacies. And that continued out through 2018 when we measured in morphine equivalents. That's reflected as well in the number of patients receiving opioids. So the number of patients in Nova Scotia receiving opioids over that same period of time dropped dramatically, particularly from 2015 through 2018. Almost 20,000 less people received opioids in that period of time. So how did we wind up in this place where we have all these people dying and having serious morbidity and mortality, and then creating guidelines and squeezing the balloon, as it were? Well, really, it's again the Swiss cheese model that we talk about in crisis management. If things line up just right, either good things or bad things might happen. Use this is often used in accident reconstruction in the aircraft industry and in anesthesia as well. So when we think about education, this is data from here in Toronto, from Judy Watt-Watson. I'm sure many of you have seen this slide before. This was published in 2009, so the data was a little bit before that. It shows us that all those new physicians that were being created in the early part of the 2000s were not educated nearly as well in the management of pain as were their colleagues in other health disciplines. In fact, the best educated were the veterinarians. And I don't know, maybe we should have been sending our patients to the vets, but I'm not sure I would advocate for that. But certainly we weren't seeing education at the undergraduate level that was matching the problem. When my colleague John and I, around that time, around 2009 or 10, we were asked by many people, patients and the hospital and some government agencies, where do we send prescribers to get educated on how to prescribe safely? So we looked across Canada, did an environmental scan, try and find some programs and CME programs for prescribing, and there were nothing at that time. And so we created one, and now there are several that have been developed. But there was also funding, right? This is data from the US, in funding for pain in the US from 2003 to 2007. So in the time when we recognized that there was a significant problem with chronic pain and that we needed to do more to treat it, funding for pain in the US, this is NIH data, dropped from 0.75% of funding, so less than 1%, to 0.61%. So it went from small to less. And this was at the time when the economy was broiling along like nobody's business, when you couldn't pass by a bank, but they wanted to hand you money. And pain funding was declining. Same thing in Canada. In Canada, during the same period of time, only 1.1% of CIHR funding went to pain research. And 0.25, or 1/4% of all health-related research funding went to pain funding. Pitifully small amounts at a time when the economy was at its peak. And then came our friends in pharma. So our friends in pharma had a huge impact. This is data from a court filing in Chicago, where they looked at the amount of money spent on advertising and the amount of prescriptions. So there's a number of things about this slide. This is in hundreds of millions spent on advertising. And what you could tell is that advertising works. As the dollars spent on advertising go up, so do the number of prescriptions. In about 2011 or 12, the amount of money spent on advertising dropped, so did the number of prescriptions, immediately followed by a resurgence in advertising dollars. So advertising works, but it's how the advertising that was done that was more concerning. This is a partial list. This list should be about 20 long, but then it starts to get too small. Particularly in the US, but here in Canada maybe to some degree, although I couldn't find good Canadian data. Pharmaceutical companies funded essentially front organizations. These were patient advocacy organizations that were funded. The American Pain Foundation, which is now closed down, was almost entirely funded by pharma. 85 to 88% of their funding came from pharma. American Association for Pain Medicine, similar. American Geriatric Society continues to this day. But that fourth one is the one that really concerns me. This is the Federation of State Medical Boards. Receives an enormous amount of money from pharma. That's the equivalent in Canada of FEMRAC, or the Association of Colleges. So they were funded for a number of reasons, advocacy at various levels, but also guideline development. So the American Pain Foundation, American Academy of Pain Medicine, American Pain Society, American Geriatric Society, and a whole list of others were all funded to create guidelines. All of those guidelines support the use of opioids for the management of chronic non-cancer pain as usually second line. And there's tacit attention paid to non-opioid pain strategies. The American Geriatric Society said that the risk of addiction was exceedingly low in older patients. There's no evidence for that. In fact, older patients are at higher risk of overdose, probably because of polypharmacy and other sedating medications, and frailty, etc. The Federation of State Medical Board created a set of guidelines, again, supporting the use of opioids. None of these were particularly evidence-based. This is another thing that happened, and it continues to this day, and it continues in Canada. The cultivation of key opinion leaders. These are physicians, and now nurse practitioners. Key opinion leaders were cultivated by pharma. They were approached. I've been approached many times. And you didn't have to be an expert or a specialist to be approached, particularly in the US. They're cultivated, they were asked to do writing or consulting or editing or name recognition, give your name for recognition, often to give talks, and you're paid very handsomely to give talks. The talks are prepared by pharma, and you simply have the slides. And the content of those talks is tightly controlled by the producer. They're offered membership, paid membership on boards, and they receive direct financial and professional advancement. We're seeing this now with nurse practitioners. Within 1 or 2 weeks of nurse practitioners in Nova Scotia and New Brunswick being allowed to prescribe opioids, they were directly approached by pharma to start giving talks. It happened almost instantly because now they can prescribe. But it continues to this day. I've taken the names off of here because there's nothing to be served there, but this is from CMAJ in May of 2017, immediately after the guidelines were published. This is a pro-con articles. Will new opiate guidelines harm more people than they help? So for the affirmative, yes, they'll harm more people, or we shouldn't be using these guidelines. This was in the bottom corner of the page in very small print. So the author had, suffice it to say, has significant ties to pharma. The rebuttal, or that these guidelines will not harm people, was written by somebody who has essentially no ties to pharma. He's a very well-known physician here in Toronto. So this continues. We've all seen these books. I'm sure everyone, you've seen these. They're not so, they're sort of antiques now, but the one on the right there, or on my right, was funded and distributed and published by Purdue Pharma. The one on the left is the American version, also received significant funding from Purdue Pharma. The one on the right, on my right, your left, it was ubiquitous. In medical schools, in residency programs, it was in every clinic, in family doctors' offices, it was everywhere. And it was essentially became, for a period of time, the sole guide to prescribing for pain. And it was very heavily weighted to the use of opioids, particularly oxycodone. Pharma created a language. This was particularly interesting. Many of us have heard of the term pseudo-addiction. Pseudo-addiction was coined in 1989 in a case report of a 17-year-old boy who was dying of a lymphatic cancer. He was poorly treated in hospital and died in agony. And his behaviors, he's a 17-year-old boy who's dying, who's got pain, he acted out. And he was asking for more pain medication and he was behaving inappropriately. So they called it opioid pseudo-addiction, a euphemism for undertreated pain. Purdue Pharma then took this term and they marketed the term. And I've just taken it out of the prescribing course. That's how pervasive this was. But what it was really touted as is, if you see somebody who is behaving in a way that you would expect somebody with addiction to behave, so if they're asking for higher doses, asking for earlier refills, they're asking for more tablets, they're behaving inappropriately in the office, you have to consider first that it could be undertreated pain, and the answer to undertreated pain is more opioids. And if they continue with the behavior, it's probably undertreated pain, so more opioids. So that's what pseudo-addiction was. And it was a term essentially promoted by the pharmaceutical industry. They fabricated some of the stuff. This is testimony around the submissions to the FDA. And I talk about the FDA because Health Canada follows the FDA. The studies around, so Purdue Pharma was trying to create a niche in the market for 12-hour prescribing. Because if you have the only 12-hour drug, then you have the market. So they were promoting OxyContin as Q12H. And the data for that came from studies where the patients were given OxyContin at 12 hours, but they were also given breakthrough short-acting oxycodone throughout the day. Because, and this is one of the studies, the authors of the studies that went to the FDA, he said, we knew that it was at best, at lower doses, a 6-hour drug, and at higher doses was maybe a 10-hour drug. When I did my fellowship here in 2005 and 6, we knew that it was at very best an 8-hour drug, which worked perfectly well because if you have the niche market for 12-hour drug and you know that it doesn't work for 12 hours and word gets out that you should give it for 8 hours, you sell more. And that's exactly what happened. They also did some interesting stuff with the data, and this is data that was sent to the FDA. This is the data for blood levels of oxycodone that was sent. It looks like that, if you look at that, looks like the blood levels stay fairly stable until you recognize that this is a logarithmic scale. So those blood levels do not stay stable. But that's what they sent to the FDA and got approval for. They also created this narrative. that if the medication's not working, the next step is a higher dose, followed by a higher dose, followed by a higher dose, and continues on, both for oxycodone and this is also for Butrans, for the patches. And then we have at the end of the line, we have prescribers, right? The folks who are writing the prescriptions. So if you think about it, in the early part of the 2000s, 2005 to 2010, you have prescribers who were primarily educated to manage acute illness. And they're now awash in patients with a chronic illness, coming in with chronic pain of all kinds. And they're under pressure from so many areas. More patients, sicker patients, colleagues who are pressuring them, practice management stuff, because fee-for-service is not paying them well enough to do chronic pain management, et cetera, et cetera. They're getting ever more busy. The solo practice model is becoming more and more problematic. You find people getting isolated, and their only contact with CME for many years, until the colleges mandated CME. That only came a few years ago. Sometimes their only education was the pharmaceutical rep coming to the door. And then you had the regulators. The colleges, physicians believe that the regulators are always there, breathing down their neck. You have influencers, the pharmaceutical reps who are at their door. And the education programs, you get a nice dinner and somebody stands up, the key opinion leaders, and the textbook that arrives courtesy of the pharmaceutical rep. And then this problem of threats that nobody really paid attention to for many years. And we were hearing about this. A couple of residents did a really good study in 2000. I'd say it's really good, but they were my residents, so I have to. But it was. They're very good physicians, actually. They looked at the abusive incidents around the prescribing of chronic opioids. They surveyed 300 and some odd physicians at a conference in Halifax. We had an enormous response rate. We had a 51% response rate. For surveys, that's good. Usually you're like 20% at most. If you even look at the bottom, at the severe abusive incidents, 17% of physicians had severe abusive incidents. Now, of all of the respondents, 98% said they'd had at least one type of an abusive incident of some kind in their practice. So it's universal. But 10% reported being sexually harassed, 10% reported being stalked, 5% were assaulted, and 1% were sexually assaulted. The really chilling ones were the folks who were stalked. That is really chilling. And I've had phone calls from some of those people. The worst case was one who I actually counseled to close the practice and leave because she was under such threat. So we have this intersection of a growing need for some treatment for an illness is large and getting larger. We had the creation of an educational vacuum, an educational need, and a need for a shift in our education. There was lack of research funding, we had aggressive marketing, we had pharmaceutical influence, and we have prescribers under pressure. So it might no wonder that there was a problem. But some things have changed, right? There have been some changes. So we have had the development of guidelines, and I would argue that these are very good guidelines. They're put together based on the best evidence we have, and create a process for best practice that, if followed, will keep the patients and the public as safe as possible. We're seeing a response now from all levels, and the federal government has even got involved because they've recognized that this is a problem. In 2016, there was a great deal of publicity around the Federal Opioid Conference and Summit, which ultimately released a statement of action to address the opioid crisis. And from that came the Canadian Drugs and Substances Strategy, which addresses many of the issues: prevention, enforcement, treatment, right down to funding. They recognize that funding for research and care is really important. And if they don't do it, who else is going to do it? And we've seen what happens. British Columbia declared a state of emergency. They were and continue to have multiple deaths every single day. I think the worst was like 90 in a day or some ridiculous amount. But this allowed them to shift significant amounts of money into treatment, research, crisis management, that sort of thing. Ontario has stepped up, and they through Health Quality Ontario, has created a set of guidelines and standards for prescribing for acute pain, for chronic pain, and for substance use. And there's a number of other initiatives. And these aren't the only provinces that have stepped up. Nova Scotia has stepped up as well. They've looked at this in a broad way. They've looked at things like management of prescribing, education, treatment for people who have substance use disorders, and also at law enforcement and mitigation of legal issues. There's also this issue of industry relations. So there has been some work going on there, but I would argue that it needs to be updated somewhat. Because it's much of our industry relations guidelines are based on this document. This is the 2008 Association of American Medical Colleges Task Force Guidelines. And they talk about how we should adjust our relationship with industry. Because if you think about it at that time, around that time, pharmaceutical reps would be coming in to visit the medical students and the residents and promoting their things right from the get-go. They said, they argued for transparency, they argued for separation from learners, they argued for declarations of conflicts of interest and that sort of thing. They were adopted then by universities, including my own, adopted and somewhat adapted by different organizations, including the College of Family Physicians of Canada and the CMA. And I think we're probably due for an update, because I think, as we've seen, the conflicts that we have really can influence a number of things. One, who asks the questions when we do a study? If the funder is asking the question, they already know the answer that they want. And you can guide the answer by the question you ask. And if you don't have a way to mitigate the influence of the funder, whether the funder be government or industry, everybody has an agenda. So we have to have some way to mitigate that. So there are some strategies that could be undertaken. Maybe we need to have better declaration when we publish something. How is this funded? Who asked the question? And have it in large, bold print. And maybe have, as part of our discussions in the paper, what are the potential impacts of the funding of this study or of the conflicts of its authors? And maybe that needs to be written separately by someone other than the author of the study. Who knows? Research funding has improved. This is just a list of some of the CIA and CIHR funding. There's somewhat more and somewhat larger grants that have been coming out from non-pharma funded sources, focused on addictions and somewhat on pain. This is one of the most important ones. This is the SPORE grant. It's a $25 million grant through CIHR that was awarded a couple years ago. It was spearheaded by Norm Buckley in Hamilton and Patricia Poulin out of Ottawa. They pulled together matching funding for $12.5 million. That's no small feat to get $12.5 million in bits and pieces. But it's from 26 partner organizations. It includes pharma, but it also includes a number of academic organizations, hospitals, patient advocacy groups, etc. And this is sort of a list of them. And Norm sent me this data and gave me carte blanche to speak of it as I would. But maybe it's a way to diffuse the influence of any one group by bringing together multiple funding groups to diffuse the influence of any one. That may be one of the things that can help with the conflicts. Pharma has shifted. Pharma's been under enormous pressure to stop what they've been doing. And in fact, Purdue Canada last July, or actually it was in June, they sent a letter to the Minister of Health and said, we will stop marketing opioids in Canada. We'll still sell them, of course, but we will stop promoting them. And Health Canada responded and said, thank you very much, but we're also going to severely restrict the marketing of opioids. They may still approve them for use, but they will severely restrict how they're going to be marketed in this country. We'll see how that works out. There have been changes in education. This is the logo for the prescribing course. It's an interprofessional course. Physicians, pharmacists, nurse practitioners, dentists, and nurses are all welcome. It's funded for all the medical students at Dalhousie, family practice residents. Workers' compensation across Atlantic Canada has kicked in funding to provide all of the family practice residents with the opportunity to go. It's been running now since 2014, and it's had about 600 and some odd people come through. And we've run it about 30 some times. We're seeing more and more things come out in the literature around education strategies and how education for pain can be focused. And even on parts of the prescribing process, we're seeing some how to interpret urine drug, educational strategies to interpret urine drug screening, etc. And we're seeing evidence from things like the ECHO program here in Ontario on how we can disseminate education, how we can get it out to the public. And Andrea Ferlin and her group have done a great job of showing how we can use a hub and spoke model and get the word out. Prescription monitoring programs have a huge impact. This is Beth Spruill's work with the Canadian Centre for Substance Abuse from 2015, and outlined really what the ideal prescription monitoring program should look like. It should monitor all drugs that can be abused. It should provide real-time information to the physician and the pharmacist. It should have accessible data so that the physician and the pharmacist can have real-time information. It should provide unsolicited reports to the prescribers and the pharmacists. It should have data that's available for research, and it should also have a means to do quality assurance. And actually, the program in Nova Scotia meets all those requirements. The other thing that wasn't mentioned is that, if possible, it should supersede FOIPOP. So that you can, because if you can supersede FOIPOP, then you don't have to ask permission to look at a document like this. So I don't have to look for permission. If I'm seeing a patient, I can just pull this up. This is our e-access. I can tell what this is in real time as well. I can tell what opioid, what dose, number of tablets, who prescribed it, where it was dispensed. So I can know if a patient has seen another physician, if they've changed pharmacies, if they've had an early dispense, if they have medications that I wasn't prescribing. Now we're adding benzos, so we can see if somebody's getting medications that we didn't know about. And we can see that in real time, which is a huge asset. There are changes at the practice level. This is prescription monitoring stuff that we did. This is an intervention. We created a risk assessment score. So we took a number of factors out of our data. So we looked at large tablet numbers, length of prescriptions, patient age, first fills versus part fills, and a couple of other things. We sort of mixed them up and did some weighting and did an internal validation against other prescribing data. And we created this report. This is one page of a 30-page report. And what it also allowed us to do was to send a report that compares an individual to their colleagues across the province. So you can see how well you're doing in a number of ways. And the thing came up with a single score that ranged from 0 to 180, 180 being the highest risk. And then we targeted the top 100 prescribers in the province. And we sent them an unsolicited report with a letter that explained what the report is and how to interpret it. And it was signed by the chair of the board, who just happened to be the chair of the College of Physicians and Surgeons. And it has had a huge impact. From 2015, when it was launched, to 2018, this is what we saw. If you look, and we just sort of put these arrows together the other day, but 50% decrease in large opioid prescriptions. So we targeted prescriptions exceeding 360 or 540 per month, because that equates to 12 tablets or 18 tablets per day. Somewhat arbitrary, but we took the low-hanging fruit. And long prescriptions, more than 60 days. We also looked at first fills and part fills, but the big drop came in the large prescriptions. We also saw a 33% drop in the 60-day supplies, in the number of tablets going out, etc. And we saw an increase, or an uptake, in the frequency of prescriptions, the total number and number of part fills. So what we were seeing was more frequent, smaller prescriptions. So it's had an impact. Not all, I would say that it's had an impact. Of course, the guidelines were in there as well and other external pressures. But we know it works, and it's at the prescriber level. Here in Ontario, and the reason I'm saying this is because it's clear that interventions at the prescriber level have an impact. In Ontario, the high-dose opioids were delisted, and it had almost no impact. Because when you delist the 30 milligram tablets of hydromorphone or the 200 milligram tablets of morphine, what happened is the physicians just simply wrote for more smaller tablets, maybe a higher risk problem for the public, and a third of the people who were receiving opioids, in fact, switched funding. So either to a private or they paid cash. So it really didn't change the amount of opioids going out. In Oregon, what they did is they required prior authorization for doses above 120 oral morphine equivalents. And that had a profound impact. Because if you had to fill out another form to write a prescription, you just simply wrote smaller doses. And that's what they saw as an uptick in smaller doses. So the physicians simply didn't write the larger ones nearly as much. And then there's the Inverness model. This is Inverness, which is on the coast of Cape Breton. I don't know how many of you have ever been there, but right up here is a links golf course. So if you like to play golf in the wet and the cold, that is the place. It's considered, people go there and they look for the bad weather because apparently that's what you want to do. And up the road, you can't really see up the road there, but there's a distillery up the road that makes a fairly decent whiskey and has a nice chalets and stuff, and there's a brew pub in town there. But all that's really irrelevant, but it's one of my favorite places, and some good friends work and live there. What they did in 2012 was unique, and it was so unique that it was presented at Parliament. One of the physicians in the community was retiring, and he was leaving behind an enormous practice after about 45 years. He was in his 80s, of people on opioids and benzos. And the other physicians in town knew that there was a crisis coming. And they said, look, okay, we have to do something. So they gathered together with all the healthcare providers, pharmacists, nurses, physicians, some of the funding agencies, and the police, everybody in one room. The Atlantic Mentorship Network and the Prescription Monitoring Program, everybody in one room, and they announced, this is what we're doing. And essentially what they said is we're all going to practice, keep our own practices, but we're going to practice in the same manner. We'll take these patients into our practices, but if they come to our practice, they must have a urine drug screen, and they must have an opioid agreement. And we will not refill prescriptions in the emergency room, and we won't refill prescriptions of somebody else's patient unless we have prior authorization, like for vacations or illness or what have you. 6 months later, they talked to the pharmacist to see how it worked. They didn't publish this data, unfortunately, but they talked to one of the pharmacists. 80% decrease in Percocet dispensing in 6 months. And the law enforcement reported that they had a dramatic downturn in opioid-related crime. They actually said, we're really struggling to find work to do now. And I could tell you, because I drove up there about 6 or 8 months after they did this, and the road going up there kind of is winding along the coast, right? And around every corner was an RCMP car. So if you dare to go up there to play golf or whatever, be aware that they're out looking for business. But it's had a profound impact. And when I presented this at public forums, and when my colleagues from there would present it, they said, well, isn't that the way you're supposed to practice? And in fact, it really is. What they did is really what they should have been doing in the first place. What we all should be doing, not what they should, but what we all should be doing. Final thing that we can think about, and I think about probably more than most, is about the process of prescribing. And I'm not going to go through the whole course because that's what the prescribing course is about. But it really boils down, this comes from the 2010 guidelines, and it really boils down to 4 things. the assessment of the patient and the patient's risk, so the assessment of the problem and the risk, so particularly the risk of addiction. Prescribing, if you're going to prescribe a medication, particularly if it might be for the long term, you should prescribe as a trial to make sure you have the right medication and make sure the medication is going to work and it will meet its goals for management of pain and function. And you have to have a way to monitor it. And when we're managing pain, that's more difficult than, say, blood pressure, because we can't just measure the blood pressure and see if it's working. So we have to know whether we're meeting goals, whether there's aberrant opioid behaviors, urine drug testing. We have to know whether the patients are taking more or earlier or later, all those kinds of things. It's best if we can create some sort of system in our practice. And we have to have a way to manage problems, whether that means by tapering, whether it means by reducing the interval at which we dispense medications or the type of medications we use to reduce the number of tablets, whether it means treating an incipient addiction or substance use disorder that we've now created. But we have to have some way to manage problems and to manage boundaries. We talked earlier today about using the red pajama, blue pajama thing, which is really comes from managing children. I wish I could remember the name of the woman who wrote it, but it comes essentially my wife gave me this book when we were going to have our first child and said, this is really important, this is how we're raising our children, and you should read it. So I said I did. And what it really says is you give the person two choices, only two, and they have to be choices you can live with. So, it might be, do you want to come down on the benzos first or the opioids first? Or as the staff here told me today, do you want to start in the physiotherapy program first, or do you want to come down on the opioids first? Or do you want to do CBT or reduce the opioids? Whatever it is that you can live with, you give them two choices. And you gain from that the patient's input. So the patient is now part of the process. You're not just telling them what to do. They're making the choice. They've got skin in the game. So we have had a significant prescribing problem, that perfect storm over the past 20 years or so. It's really been like Swiss cheese. That's all lined up perfectly, where there's a number of factors that have weighed in and a number of players that have weighed in, both in creating the problem and now in trying to solve it. And we've got a balloon that we've squeezed in various places and it keeps popping up. And I would argue that probably as we move forward, one of the major things that we can do is to try and figure out where the balloon's going to expand next and try and get 2 steps ahead. I'm not much of a chess player, but that's really what you have to do in chess, is figure out 3 moves ahead or whatever. I don't know what Garry Kasparov or what did, but I'm nowhere there. We know that our prescribing is getting better across this country. Things are getting better from that point of view. And we are seeing changes coming from all levels, right, from the federal government down to the prescriber's office. And I think that there's hope here that we can mitigate this and hopefully learn from it as we move forward in other areas of medicine and other drugs that are coming online now. And I think now we can probably talk a little more about this.